can start.
Thank you. Good afternoon, everyone. I am Dr. Isha GUPTA, and I will be presenting a case series of few rare ocular foreign body complications that we encountered at our tertiary eye care center. Foreign bodies may enter the cornea by trauma, surgery, or direct or indirect contact by rubbing of the eye. There have been multiple reports in the past of animal hair like tarantula or caterpillar hair causing conjunctivitis, chorioretinitis, or ophthalmia nodosa, but reports of human hair entering the cornea are rare. The cilium after entering the eye may remain inert or may lead to a variety of complications like iridocyclitis, inflammation, corneal decompensation, endophthalmitis, or even sympathetic ophthalmia. Similarly, bee sting injury to the eye is a rare occurrence with a sequelae ranging from mild conjunctival hyperemia to corneal decompensation and secondary glaucoma. Due to rarity of such injuries, there is no proper consensus or guidelines regarding their management. The aim of our presentation is to describe the management of few such rare foreign bodies and their sequelae that we encountered in the last 1 year. Beginning our series of cases, we present a case of retained intracameral eyelash following trauma in a 24-year-old male who presented with an injury with a plastic object in the right eye. On examination, the vision was finger counting 3 meters. On slit lamp examination, there was conjunctival congestion, seal corneal laceration of around 1 into 2 mm, and AC reaction with a 1 millimeter hypopyon. On further examination, we noticed a hair lash in the anterior chamber adherent to the anterior lens capsule, which was confirmed on AIOS2025 as a hyperreflective dot. Considering it to be an inflammatory reaction, the patient was started on oral steroids, topical steroids under antibiotic cover. In 2 weeks, there was development of leukomatous opacity at the site of laceration with the inflammatory reaction decreased. So the patient was undertaken for lash removal under local anesthesia with the help of vitreoretinal forceps. The postoperative vision of the patient was 6/6. Another case of retained intracorneal eyelash following trauma presented in a 10-year-old female. There was history of trauma with back of cleaning stick. On examination, the vision was 6/24. Slit lamp examination showed conjunctival congestion and 2 intrastromal foreign bodies that looked like hair lashes with surrounding stromal edema. AIOS2025 confirmed eye diagnosis that showed deep intrastromal hyperreflectivity. So the intrastromal lashes were removed after alcohol epithelectomy, and they were sent for histopath confirmation. Postoperatively, the patient had unaided vision of 6/6 with a faint nebular corneal scar. Then cases of bee sting presented to our center. 19-year-old male presented with diminution of vision in the right eye since last 6 months. There was a definitive history of trauma with bee sting 7 months back following the diminution. On examination, the vision in affected eye was finger counting 3 meters. On further examination, there was diffuse corneal edema with epithelial bullae. AIOS2025 showed increased corneal thickness. So a diagnosis of toxic endothelitis following bee sting injury was made, and the patient was taken up for right eye endothelial keratoplasty. This is the postoperative clinical photograph in AIOS2025 at 4 months showing a clear cornea and well-centered and attached lenticule. Unaided vision of the patient was 6/60 at 6 months follow-up, improving to 6/18 with RGP contact lenses. Another case of post-bee sting corneal decompensation presented in a 21-year-old male who had history of diminution of vision in the right eye since last 6 years. There was a history of bee sting injury 7 years back. The vision at presentation was finger counting close to face. On examination, there was diffuse corneal edema with anterior polar cataract. On AIOS2025, we showed increased corneal thickness with anterior polar cataract. So a diagnosis of toxic endothelitis was made, and the patient was planned for right eye DSEC with phacoemulsification with IOL. This is the postoperative clinical photograph and AIOS2025. So intraocular cilia following penetrating injury are rare. If there is no inflammation, the patient can be kept under observation. However, in presence of inflammation or infection, surgical removal is necessary. Similarly, corneal sting by bee or wasp can lead to toxic or immunological ocular inflammation provoked by the venom compounds. Removal of the stinger is advised in acute cases. However, in cases of chronic corneal decompensation, DSEC is a viable option. So to conclude, response of eye to cilia is unpredictable, ranging from lack of reaction to severe intraocular inflammation. Decision to remove the eyelash depends upon the severity of inflammation or infection. The consequences of bee sting injury can be devastating. The need for keen observation to look for the bee sting cannot be overemphasized. Finally, if the primary pathophysiology in chronic cases is endothelial dysfunction, so lamellar procedures in the form of endothelial keratoplasty are a better option for visual recovery. Thank you.
So good presentation.
Thank you.
So what do you do if about the cilia that is there in the anterior chamber? They migrate.
Yeah.
So one photograph you have shown that the patient has cataract, and you have gone and then dissect with phaco.
In the bee sting injury, yes, ma'am.
Yes, yes. So what have you ever seen cases where you have found you could remove the stings from inside?
In our center, till now we haven't encountered any such case of acute cases of bee sting injury, but there have been reports that I have read of acute cases presenting with the bee sting in the cornea, which were removed.
Yes, but usually they migrate inside.
Okay.
And the case that you showed with the anterior polar cataract.
Yes, ma'am.
So how did you manage? Was it already fibrosed when you did the rexis?
The anterior capsule was fibrosed, so the rexis was a bit difficult.
Yeah.
So we used a capsular rexis forceps to make the rexis.
Okay. Thank you.
Thank you, ma'am.